guys, here we go. We're going to start on human anatomy and physiology, and we're better to start chapter 1. So this is going to be a 3-part video series on this one. Again, going over kind of an overview of it, of anatomy and physiology. We'll go over directional terms. We'll go over some of the basic chemistry. Now, some of this we probably already covered in pathophysiology. That's okay. It never hurts to go over it again, okay? So let's get to it. And again, anatomy is the study of structure that makes up the organism. The gross anatomy is your bigger components, things that you can see, where microscopic anatomy obviously requires the use of a microscope in which to do it. That's usually your cellular problems that you might be having, where you're having to actually look at tissue samples, something of that nature, being the microscopic anatomy. Now, physiology, on the other hand, has to do with the process and function, okay? Again, pathophysiology is that of where you've got the presence of disease, which is causing an interruption in that function. And the really key component here is the concept of homeostasis. Our body is constantly trying to get back to this steady state, a state of balance, okay? It wants to do that. It wants to be able to do that. So again, if there's something that interferes with that process, pathophysiology, it wants to get back to that normal state, and that's why it makes the changes that it does. We react to stimuli that we receive. That is part of what we are as an organism. So again, systemic anatomy, it studies each organ system separately, and then regional anatomy will go to that very specific. So if we're talking about the thoracic problems, again, we'll be talking about things about the heart, the lungs, or other organelles, other organs in that area. And we usually use the systemic approach, and that's what the book is going to use. It breaks it down into body systems. And again, now this is just kind of an overview. We talked again in patho a little bit about this. Atoms make up molecules. Molecules make macromolecules, which will then form together to make organelles, which will then form a cell, which is, again, a bunch of organelles providing a specific function. The tissues, cells become tissues. Tissues, again, same type of cells grouped together usually to perform a function. Organs, again, a bunch of tissues together to perform a specific function. Organ systems, same process, and then it goes to the organism, us. Okay, so that's, and I would probably know that order. That order is kind of an important thing that we understand. So the different the body systems that we're going to go over: skeletal, muscular, circulatory. Your lymphatic system, kind of a misunderstood one, but it has a lot to do with our immune system as well. And again, your respiratory system going along with that. Go on with your circulatory system. Your nervous system, gastrointestinal system, how we get energy or how do we absorb nutrients into our body. Urinary system, how we get rid of all the waste product. Reproductive, so that we can continue as a species. And by the way, the reproductive system is the only system that an organism can live without, and it doesn't affect it. It eventually affects the organisms, but it does not actually affect the organism itself. Endocrine system, and of course, that's what control function. And then, of course, your integumentary system, which is integumentary is for our protection and temperature regulations. So topographical anatomy, it identifies the superficial landmarks. Again, you got a bump for your clavicle. Again, that would be an example of a superficial landmark. Your xiphoid process at the very tip. Again, another example. And then anatomical position is usually and by the way, everybody messes up this one. Anatomical position is hands up towards the person with the palms up, hands down at the side. So very important to understand that anatomical position, because when we start talking about dorsal ventral, that's what we're referring to as that base anatomical position. So again, here's our picture of the guy in an anatomical position. They have several different, and this is actually a really good slide to understand the difference between different directions. Again, medial is more towards the middle or the midline. Lateral is to the outside of it. Superior, again, is more towards the head. Inferior is down towards the head. Again, proximal, distal. Your wrist is distal to the elbow. but your elbow is, again, it's proximal to the wrist in comparison to the shoulder. So again, make sure that you understand the terms when we're talking about the different, when we're describing things. We use a lot of those descriptive terms, as a matter of fact, in our narratives to describe exactly where the injury is. Now, we also divide the body into planes, and usually those, again, the sagittal plane is usually a lateral plane, where your frontal kind of splits the body between front and back, and then you got a transverse or an axial plane. We use this a lot, actually, like ultrasounds or X-ray, to kind of describe how we want the picture taken. Again, your sagittal plane divides the body into left and right, and mid-sagittal is actually a down the middle cut into left and right sides of equal halves. Another one that would do, another sagittal plane would be like, let's say, your midclavicular line would be an example of just a simple sagittal plane. Again, frontal or coronal, these are directional terms. Transverse or axial, we'll talk about that, especially the axial skeleton. Your sagittal, again, lateral. Superior means it's closest to the head. Inferior means more close to the feet. Again, your medial, lateral, proximal, distal, we just kind of went over these things. But make sure that you understand these terms. It's so very important that you understand the difference. If I tell you that the patient has a cut that is, again, distal to the elbow, you know where to start looking for that cut. Again, your anterior, posterior, the anterior is also known as your ventral side. Posterior is known as the dorsal side. The way I remember this is that a dorsal fin is on the back of a dolphin. So again, your dorsal fins are on the back. Again, your midclavicular line, usually these are lines that we use to describe where to put locations. Since you guys have already been doing EKGs, you know that we place the V4 lead on the midclavicular line at the 5th intercostal space. That would be an example of using that as the descriptor. Again, mid-axillary line, it goes straight down the middle from the axilla to the waist. Your anterior axillary line is the parallel line that's drawn just an inch or so in front of the mid-axillary line, and then your posterior is this, again, on towards the back. So there's your mid-axillary lines. Again, mid-clavicular lines showing those. Now, your abdominal quadrants, and I remember we used to use abdominal regions. There were 9 of those suckers. But again, we basically break this down. This is back to EMT school here. But what I would know about this is the different organs that are in those different quadrants. I would definitely start learning those organs and where their locations are. So if I said, hey, what's in the left lower quadrant, you would be able to tell me what different organs are in the left lower quadrant. And by the way, the reason that we really want to know that is because that's probably going to give us a clue to what's wrong with the patient, and very much so. Movement, again, we're going to talk about range of motion and the full distance that a joint can be moved. Again, there's different types of movement. Your flexion, and again, extension, flexion. Again, bringing the elbow up, that would be an example of the flexion. So extension, again, is the exact opposite of flexion. And again, and by the way, your neutral movements. So when we're talking about a patient that's in the supine position, and the difference between having the C-spine flexed or C-spine extended, we talked about this a lot when we were talking about how to intubate a patient. If you really stop and think about this, again, we wanted the neck kind of extended and the head actually up a little bit, so to get into that sniffing position, if you will. But again, most of the time when we're laying somebody flat, to maintain airway, we usually have to use an extension of some sort in order to have that. So again, you can go too far or to the largest extent, a hyperflexion, hyperextension. And we get a lot of these, by the way, in our joints, ankle, wrist injuries, where again, you can get these that they go move too much, and that's what causes damage. And of course, supination and pronation. Pronate means, again, supination is you're on this with the palm up. Pronation is again the exact opposite of that. So again, when they discuss that with the movements, and again, this is a really good example, by the way, of a what's known as a silver fork fracture, or a Colles fracture, if you will. Again, that usually has the break here, and this in the shape of the fork. Again, you got internal and external rotations, and it describes toward moving it medially or laterally, whatever that happens to be, from the midline. We use this a lot with hips, by the way. Hips is usually our big one there. And then, again, your rotation here. Again, rotations can be applied to spine as well, whether it twists along its axis. Placing the chin on the shoulder to rotate the cervical spine, that would be an example, again, of rotational movement. Abduction versus adduction. The way I remember this is that you add it to the body. So if you're bringing it closer towards the extremity, closer to the midline, you're adducting it. If you're pushing it away, again, you're doing an abduction. And again, remember, if it goes back towards the middle, towards the center, that you're adding it to the body. So therefore, an adduction. There's several machines like it when you're doing weightlifting that does the abduction, adduction. Positions here, again, our recumbent position is usually the patient's lying face down or leaning back. And that's your supine is usually when they're flat on the floor. They can't have the legs up just a little bit. And we usually place them in a recumbent position where they're lying down or leaning back to where, again, so usually to help protect the airway. Prone, again, it's when you're lying you're laying flat on your face, and again, with the face down, you're on your stomach. Your Fowler's position is usually the patient that's sitting up a little bit, and then semi-Fowler's is just that instead of sitting straight up, you're sitting back at about anywhere between a 30 to 50 degree angle. Usually low Fowler's is like a 30 degree, where high Fowler's is usually your around 60 degree mark. Trendelenburg, wonderful thing here. Actually, a German surgeon is what it was named after. He found out when he lifted his legs on a patient that they actually did better as far as maintaining their blood pressure. It helped to stop the blood pressure from lowering. And so, again, what he essentially was doing was kind of shifting it via gravity so that more blood got back towards the central core. It's not so much that it does raise blood pressure a little bit. Just remember, along with raising blood pressure, it can also increase thoracic pressure as well. So that's why it's kind of frowned on nowadays. It's not used as much. But it is an effective tool. Now, again, don't stand them on their heads. Again, 12 inches is all you really need. You just 1 foot, put some padding up underneath the legs. The recovery position, again, when we want the fluids to drain from the mouth, this is the one we do. Again, notice that this lady here, I'm going to mess this up, but her left arm is up above her head. It's kind of using it as a rest to allow that stuff to drain from the mouth. All right, we're going to stop there because, boy, when we get into this topic, this one's going to be a big one. So we'll get on this one the next time, and I'll talk to you then.